So good evening, everybody. I hope you're having a lovely summer so far. Welcome to our 15th webinar. I can't believe we've had 15 already. So we try and cover every aspect of living with kidney disease. And this evening, we're doing a subject that we haven't touched on before, and that's sexual relationships. So this will be recorded to watch again on our website. So if you want to watch it again, or you've got colleagues or friends that want to watch it, all you have to do is go to kidney.org.uk. Round about 10 o'clock tomorrow. It should be live on there. If you've got any questions from today's webinar as it goes along, just put it in the chat bit. And then what I'll do is I'll read it out to Nadia later on after her presentation. I won't give you name, so I'm not going to read names out. And I'll ask that question and she can then answer that as we go along. So without further ado, let's welcome our presenter for this evening. It's Dr. Nadia Sarween, and she's going to talk to you about sexual relationships and lots more. Hand you over to her.
Can you see that, Pete?
Yeah, that looks absolutely brilliant.
Brilliant. So yeah, good evening, everyone. Thank you very much for joining. So my name's Nadia Sarween. I'm a kidney consultant based in Queen Elizabeth Hospital, Birmingham, and I also work as an obstetric physician. And I'm delighted to give the webinar today on an extremely important topic covering sexual relationships in patients with kidney disease. So we'll have a brief introduction. We'll cover sexual disorders or sexual dysfunction in chronic kidney disease. We'll then go on to fertility issues, a brief overview of pregnancy, preconception planning, and also cover contraception. Now, because it's quite a big topic, it is a bit of a whistle-stop tour, but I'll be very happy to take questions at the end. So why is this topic important? Unfortunately, it's an area that's often overlooked in routine clinical care, and that's due to a number of factors which have been identified in with surveys questioning patients and healthcare providers who manage individuals with kidney disease. And these barriers include embarrassment, and this could be the patient themselves being bit shy to bring up the topic, but also the healthcare professional as well. The clinician might lack confidence due to lack of experience, and therefore they may not engage in discussions covering this topic. Time constraints is also an important factor. The healthcare professional may choose to focus on other clinical issues, for example, medication reviews, blood pressure control, etc. And they may see this as being a less urgent issue to prioritise. And then there's also the question of, well, who should be involved in these discussions? Is it the role of the GP? Is it the kidney team? Or is it the specialist who work in sexual health or obstetrics and gynecology? And I would say that actually, given the fact that sexual and reproductive health have a significant impact on a patient's quality of life, this topic should be routinely discussed by any healthcare professional involved in a kidney patient's care, regardless of whether they're based in primary care, secondary care. So sexual dysfunction in women, we'll just start off with the women first. So this is an umbrella term which is used to describe any problem experienced during sexual activity, and then that may include reduced libido, difficulty with arousal, inability to orgasm, and also painful intercourse. And this results in a reduction in the frequency and quality of intercourse, and sexual abstinence has also been reported in women with chronic kidney disease. It is a common issue, reported to affect around 30 to 80% of all women with chronic kidney disease, and in women on hemodialysis can affect up to 3/4 of women, with 50% of this group reporting reduced libido. So it's very, very prevalent. In men, again, a number of issues are included in the definition of sexual disorders, and this can include erectile dysfunction, ejaculatory dysfunction, and inability to achieve orgasm and reduce libido. Higher rates of erectile dysfunction are reported in men with kidney disease, and in those on dialysis, it's reported to occur in 70 to 80% of individuals. So that's a staggering proportion. Unfortunately, only less than a quarter of men are thought to seek medical assistance, and again that could be due to the factors we described before, such as embarrassment or just not having the opportunity in a routine consultation. And you know, I think we'd all recognise that sexual dysfunction can significantly impact on quality of life, affecting self-image, self-confidence and self-esteem. So really, really important areas to address. What is the cause of sexual dysfunction in kidney disease? It's thought to be related to multiple factors, and these can be split into psychological or physical factors rather arbitrarily. So psychological factors would include a negative body image. So for example, if the individual is getting used to having a fistula, a dialysis line, a PD catheter, we know that unfortunately depression is more common in individuals with chronic health conditions such as kidney disease. And also if there's stress in a relationship, that can also impact on the ability for that partnership to have a normal sexual relationship. Physical factors can include anemia, the presence of cardiovascular disease, so these are conditions that can affect the heart or blood vessels, peripheral neuropathy, which are conditions that affect the nerves in the body, for example, caused by diabetes. Women may experience vaginal dryness, and also side effect of medication, for example, a tablet that can cause increased tiredness. There's also a change in the hormonal profile in individuals with kidney disease. For example, women can have lower levels of estrogen and men lower levels of testosterone, which can also affect sexual function. Is this treatable? Well, firstly, it's really, really important that an individual with kidney disease who is experiencing issues in this area is able to discuss it with a medical team. And I don't think we need to be prescriptive saying that they should be with a kidney team or the GP. It could be whoever the whoever the individual is seeing more frequently perhaps, or those that they feel more comfortable discussing a personal matter with. And even if the individual they discuss this problem with, even if they can't help, they can then be referred to a specialist in the field. And there might be investigations that are performed, for example, a blood test measuring the level of sex hormones. We would do a comprehensive medication review, treat any underlying anemia, and where appropriate, referral for counselling as well. There is potential targeted treatment options available, but it's just important to say that you know, we can't, these may not necessarily be provided by the kidney team or even by the GP, and may require a specialist referral. So for example, with women complaining of vaginal dryness, lubricants can be prescribed or hormonal replacement, and in men, medications such as Viagra, hormonal treatment, penile injections or implants, to just name a few treatment options available. Onto the topic of fertility, we know that fertility rates reduce more as the stages of kidney disease worsen in an individual. Infertility is defined as a failure to become pregnant after 1 year of trying, so having intercourse without using any contraception. The reduced fertility rates that are reported may also be related to patients with kidney disease being less likely to try for pregnancy. So, for example, they might be worried about the impact of pregnancy on their health. So, fertility disorders in women with kidney disease. So, women might with kidney disease might notice that their periods are absent or irregular. But it's important to state that the absence of periods doesn't necessarily mean that they've, achieved menopause, and that is something that should be diagnosed by a healthcare professional, and again might involve a blood test and a detailed history. As the severity of the kidney disease advances, infertility becomes more common. So, for example, so in women with CKD stage 5, infertility has been reported as occurring in over 90% of these women, compared to an infertility rate in the general population of around 10%. It's worth mentioning that fertility rates have been shown to improve with increased dialysis treatment. So, for example, home dialysis, where an individual might dialyse 6 or 7 times a week. But despite that, pregnancy in women on dialysis is very rare. We know that transplantation can restore fertility in women, and that can be manifest with a return of periods which were previously absent. Menopause is also documented to occur earlier in women with chronic kidney disease, and there's an estimate of around five years earlier compared to the general population. It's worth mentioning that earlier menopause can be associated with an increased risk of osteoporosis. Sorry, just give me a moment. An increased risk of osteoporosis, especially if individuals are taking other medication, which can also increase the risk of osteoporosis, such as steroids. And also really important that women with chronic kidney disease are not denied the opportunity to receive HRT. Yes, there might need to be specific options that are chosen for them, but they should definitely not be denied treatment. And if there are any issues that they are facing, then that's something that should definitely be flagged up to their kidney team, who can then liaise with the relevant individuals. The causes of infertility can be related to hormonal changes, impaired ovarian function, and this could be related due to the effect of toxins which accumulate in kidney failure, or also treatment with, for example, cyclophosphamide as well. In general health, fertility is regulated by a hormonal axis, which involves the hypothalamus, the anterior pituitary, which are both form part of the brain, and also your gonads as well, which release sex hormones. And in CKD, this relationship is affected by a change in the hormonal profile, which can then impact on ovulation in women and sperm production in men. Again, in men also, the rates of infertility increase as kidney function worsens, and is highest in men who have established kidney failure. And the causes of this include erectile dysfunction. Again, as we discussed in the previous slide, a change in the hormonal profile, specifically reduction in testosterone levels. We know that men with chronic kidney disease also have reduced sperm count and reduced sperm quality. And they may also have conditions which have caused the kidney disease, but can also impact on fertility as well. And unlike in females, while kidney transplantation can improve fertility in men, it's unlikely to restore it back to normal. A little bit about assisted reproduction. So if an individual with chronic kidney disease is infertile and would like to have a baby, then there are options available with regards to assisted reproduction, and they would require a referral to a fertility team. So for example, in vitro fertilization, where the egg is fertilized outside the body, and also intracytoplasmic sperm injection, where a sperm is injected directly into the ovary. So, for example, in men who have sperm motility issues. If a CKD, if a lady with chronic kidney disease is going down the route of IVF, we would in general recommend that she has a single embryo transfer rather than trying to have multiple embryos to increase the chance of a successful pregnancy, because if it does end up being a twin or a triplet pregnancy, then the pregnancy can become a lot more risky for her. There's also, with going down the route of IVF, the potential to have pre-implantation genetic diagnosis. That's when embryos are screened for certain genetic conditions, for example, polycystic kidney disease, if the couple are keen to have a baby that's not affected with the condition. Egg preservation, you might have come across in the general population as being considered as an option to preserve fertility, generally is less effective, and it's probably more effective to have embryos created and then stored. I don't think it's unreasonable to suggest that individuals with kidney disease should perhaps be referred for fertility tests slightly earlier than individuals in the general population. So in an earlier slide, I mentioned infertility is defined as inability to conceive after trying for a year. So maybe in an individual with kidney disease, if they've been trying for 6 to 9 months, you could consider referral at that stage rather than waiting for the full year. Just one other point, so fertility treatment is available in a lot of private sector clinics, but I would recommend that if an individual has kidney disease and is going down the route of fertility treatment, where possible, this is performed in an NHS centre, and there's very close communication between the fertility team and their usual kidney team as well. So pregnancy, I'll just cover this briefly. So historically, women with kidney disease were actively discouraged from having pregnancy, and a lot has changed over the past few decades. And actually, the take-home message is most women who have kidney disease and have pregnancy have a successful pregnancy. So over 85% deliver a live baby, and those rates are comparable to the general population. There are increased risk of adverse pregnancy outcomes in those women with kidney disease who have worse kidney function before pregnancy, have coexisting hypertension, especially if this is not well controlled, and have higher levels of protein leak in the urine. And the main adverse pregnancy outcomes are an increased risk of developing a condition called preeclampsia, which is where the woman in pregnancy can develop high blood pressure, increased leg swelling, and an increase in the amount of protein leak from the kidneys, amongst many other clinical features. And also an increased risk of having a preterm delivery and having a baby that's born on the small side. It's imperative that pregnancies in women with kidney disease are followed up closely with regular growth scans, regular monitoring of blood pressure, urine for proteinuria levels, and kidney function tests as well. And ideally, these pregnancies should be managed in a joint renal obstetric clinic, which is essentially having a kidney doctor and an obstetrician both providing joint care, i.e. a multidisciplinary approach. And I appreciate this might not be the setup in all hospitals, but it is a model that we are working towards nationally. And even in the smaller hospitals, there will be a local hospital that does provide a joint clinic. We would recommend starting aspirin from 12 weeks pregnancy to reduce the risk of developing preeclampsia, and that continues throughout pregnancy. In those women who have high levels of protein leak in their urine, we would also start enoxaparin injections, or Clexane you might be familiar with, which would continue throughout pregnancy until 6 weeks postpartum, and this reduces the risk of developing blood clots. kidney function may decline in the later stages of pregnancy, and even if this does happen, it tends to be temporary, especially if the kidney function was reasonably good pre-pregnancy. It's more likely to be a permanent decline if going into pregnancy the kidney function was a lot lower and the stage of CKD was more advanced, for example, stage 4 or 5. There is a high chance that women with kidney disease who have a pregnancy will deliver by cesarean section, but for the majority of women, we can plan for a vaginal birth. And it's important to keep that monitoring postnatally, and for there to be communication between their usual kidney team, and that might be the transplant team and the obstetric team that have been managing the patient, supporting breastfeeding if that's the patient's preference and if their medications allow them to. And this slide, it's just illustrating a few of the women that we've managed in Birmingham with kidney disease who've had these beautiful children, and this it's the best part of my job and an area that I'm absolutely privileged to work in. And just the take-home message really is the majority of pregnancies will result in a successful outcome. It's very, very important for these pregnancies to be planned. We know that in the general population, unplanned pregnancies are associated with an increased risk of adverse outcome, and you can especially acknowledge why this would be the case in pregnancies in individuals with kidney disease. So avoiding unplanned pregnancies will hopefully increase the chances of a successful pregnancy outcome. I'd recommend that you let your kidney team know really early if you're thinking about pregnancy, even if it's something that you're not certain about. There's absolutely no harm in bringing it up. And when we see individuals in a pre-pregnancy clinic, the goal is to optimize any risk factors. So for example, if the woman considering pregnancy is overweight, we'd recommend that she lose weight, might set a target weight as well, target goal. Controlling blood pressure and switching to pregnancy safe medication rather than doing this in the context of a unplanned pregnancy and having to do it more urgently. It allows us to do it in a more controlled fashion, ensure that she's tolerating the medication change. And as per the pregnancy slide, a multidisciplinary approach is absolutely key here. And in Birmingham, there's a joint pre-pregnancy clinic that we run with the obstetricians. And if this is not available at your local hospital, there will be a local hospital which will be able to provide a joint pre-pregnancy clinic, and you can always ask to be referred. The other goal of pre-pregnancy clinics is to discuss timing with a patient who's considering pregnancy. So for example, if she's been transplanted, ideally we'd want to wait at least 1 to 2 years before embarking on pregnancy. And that kind of covers for any episodes of early rejection, being able to make those medication changes. You don't want to make them too early on post-transplantation. And in individuals, for example, with autoimmune conditions such as lupus, we'd want to aim for stable disease control for 6 months at least prior to conception. And that's because if the disease isn't well controlled, there's increased risk of pregnancy complications such as an early birth or preeclampsia. Or if your disease hasn't been in remission for very long, it's more likely to relapse in pregnancy as well. It's really important that we're helping women make informed decisions in these pre-pregnancy chats, and we're counselling the woman about her individualised risk and preparing her for potential outcomes. And it's very rare for us to discourage pregnancy in women with kidney disease. And even if we were to, ultimately, it is a patient's choice, and we will support whatever decision she makes, her and a partner make, sorry. And if it is deemed that pregnancy would be too high risk, or it's not a feasible option for them to consider, then we can also make the appropriate referrals if they would like to consider adoption or surrogacy. The other option is, for example, if we're seeing a woman in the advanced stages of her kidney disease, and her risks are deemed to be quite high, we might advise that she wait until she receives a kidney transplant, because a pregnancy with a working transplant, the risks are less than it is with having a pregnancy when your kidney function is very low. And this is something that we can also discuss. And again, folic acid, as per the general population, we'd recommend that this is taken for 3 months prior to actively trying for pregnancy, to reduce the risk of the baby being affected with spina bifida. And just to mention some of the common medication changes we discuss in pre-pregnancy clinic. So ACE inhibitors, angiotensin receptor blockers, which many kidney patients take. Now these can be stopped in early pregnancy, but if it's appropriate, we might switch before pregnancy, and then continue with the new medication throughout pregnancy. Just makes that transition a little bit smoother. But if the individual has high levels of protein leak, we may not want to stop the medication before pregnancy and prefer to stop it right at the start of pregnancy. Mycophenolate is a commonly prescribed medication in individuals with kidney transplants, and this is a no-no in pregnancy due to increased risk of pregnancy loss and congenital malformations. We'd advise to switch over to an alternative such as azathioprine for at least 4 months before trying to have the baby, because you need to allow for the MMF to wash out the system as well. SGLT2 inhibitors are being prescribed more commonly in kidney patients, such as dapagliflozin, and the current recommendations are that this stops 6 weeks before conception. But again, all of this is discussed in preconception counselling, and any information that's given is then passed on to the usual kidney team and the GP. There are patient-friendly websites as well. For example, there's the BUMPS website, which talks about individual medication and its safety data in pregnancy, and the LactMed database, which covers medications in breastfeeding. Contraception is often missed as a topic in routine clinic appointments. And again, it's a very, very important topic to cover, especially given that we were just discussing how important it is to try and avoid unplanned pregnancies. In general, we would recommend long-acting reversible contraception, such as implants, depot injections, coil, copper coil or Mirena coil. In individuals who are at higher risk of developing blood clots, overweight or have hypertension, we'd generally recommend that they don't go for the combined preparation, which contains estrogen and progesterone, and to choose progesterone only preparations. And there's lots to choose from. I find that the progesterone mini pill, for example, Cerazette, is very well tolerated by patients, but lots of individuals prefer not to have to take a medication daily. And so, for example, going back to the implant or the depot might be more appropriate for them. Barrier methods are not effective as a sole method of contraception due to the high failure rate, but do reduce transmission of sexually transmitted diseases, so could be used alongside another method of contraception. And emergency contraception can also be used by women with kidney disease. So it was a bit of a whistle-stop tour, but we've covered sexual dysfunction and reproductive health issues in kidney patients, and these are incredibly important topics to recognise and address in our routine care that we provide our patients, and that's because they have a significant impact on quality of life. And I think we should definitely be encouraging both patients and healthcare professionals to discuss these openly. Let's get rid of those barriers, and I think this can only really be achieved by more training for healthcare professionals, increasing their confidence and in not just talking about these topics, but also for them to acknowledge where they need to signpost individuals to. And some excellent patient information leaflets are also available on the NKF website, which are illustrated on this slide. Thank you very much.
Oh, thank you very much. That was absolutely brilliant and so much detail as well. If you can stop sharing your slide, brilliant. Thank you very much. We've got quite a few questions, so let's go through them. So as I said in the start, if you want to put a question on the chat, I won't read your name out, so put whatever you like on there. Are there any stats around these people who do peritoneal dialysis having the catheter affected my body image and self-confidence?
Yeah, so there is some qualitative data exploring, patients' self-reported, perception of their image, their body image, and actually, having catheters, and not just PD catheters, but having lines, fistulas. These are all recognised, especially during the earlier phases of the transition to dialysis, can negatively impact on that self-image.
Next question, is there any evidence or medical papers to show the low rate of males seeking medical assistance or looking into why the numbers are so low?
Yeah, so there is data. I think there was a statistic that I provided that, a figure that's been reported, which is around 22% of men with, a form of sexual dysfunction had sought medical assistance, which is just over a fifth of patients. I think we can probably hazard a guess why that is, and I think it's that opportunity in a routine clinical consultation, feeling that confidence to be able to talk, there not being time constraints, but also I think just being a little bit embarrassed to bring these topics up. And I don't think that's just unique to the kidney population. I just think in the general population altogether, there probably is a little bit of stigma, and we just need to work on that stigma.
Next question, I have a spinal injury as well as CKD. On hemodialysis, any advice on sex positions as well as the ability to have sex? I haven't had sex in 5 years.
Yeah, so again, I think this is something that I hope you've is that a male or a
Yeah, a male,
female?
that one is, yes.
Male, yeah. I mean, that's, I really hope that you have been able to discuss this with, a healthcare professional, be that your kidney specialist or your GP. And I'd, definitely recommend that, there will be support available. And I would advise for you to just seek out and make an appointment and discuss this. And it could be that you are then referred to a relevant specialist, signposted to an appropriate team that can kind of review your individual needs and issues that are specific to you, so that those can be targeted and addressed.
You spoke about going to see a specialist, and someone's asked about the NHS waiting list. The question of how long is the waiting list?
Yeah, no, I think that's a very, very good point to raise, and I think it's long, and I'd love to say, oh no, this is something that would be fast tracked, and acknowledge that it's such an important, has such a big impact on a patient's quality of life, and therefore the referral will be fast tracked. But unfortunately, it will not be. But at least, I don't know, being on a waiting list will still provide that little bit of hope. But yes, I imagine that it would be something that you could potentially be waiting a little while before you are then seen by the relevant specialist.
Now, someone spoke about Viagra. Does it affect fertility?
No.
Simple as that.
Not yeah.
Right.
Not to my knowledge, anyway. I should just clarify. I'm a kidney specialist. I'm not like, I'm not.
So can you help me understand the potential impact of post-transplant medication on my sexual function and stamina? My experience, Viagra doesn't always work, and stamina is sufficiently issues since starting the post-transplant drugs.
Yeah, so I think transplantation, while it does help restore a lot of issues, I think it doesn't necessarily mean that things will completely return back to normal. And it sounds like we're not talking about fertility here. It's more about just sexual function. And just, I was referring to earlier on that these are often issues that are related to a combination of factors, some of which could be psychological and physical. And within the physical factors, yeah, definitely, medications could also be contributing. But again, I think this is something that does need to be discussed with your own clinician, and just having that detailed history, just identifying, are there any psychological triggers which could be managed with counselling. I'd probably suggest that there'd be other issues to go into first before it was put down to it being medication related. I think the commonly used transplant medications, there's none that I would think would, at the top of my head, yeah, definitely that is what would be interfering with sexual function. So I would, in your case, I think it would be really important to explore other factors before it came down to adjusting medication. But that is as important a topic as other transplant related issues, such as, I don't know, blood pressure control, medication reviews. I really, really would encourage you to discuss that with your clinician at the next appointment.
And it sounds like what you're saying is don't be shy. Consultants have heard it all and been asked all them questions, so they're not going to be shocked. So it's for your health, isn't it?
Yeah, exactly. And I can't, I'd love to say, oh, you can discuss this with any clinician. There won't be, they'll all be confident to discuss it. No, you might encounter someone who doesn't have that much experience in this particular field, but that's okay. What you're doing is flagging it up to them, and they should then signpost you to, and it could be that there's a specialist within their department who might be better suited to discuss it with you, or they might refer you, for example, men to urology. With women, it could be someone with an expertise in sexual disorders who works within the obstetric and gynecology department. So I would, please, yeah, if that's one thing that I could encourage you all to do, is just please don't be embarrassed, don't be shy. Discuss, it is such an important topic.
So we're talking about fertility now. So would it be recommended that both partners receive fertility testing if they are in the planning stages, or is it just the partner with CKD that needs to be tested?
Yeah, very
And
good
is this
question.
available on the NHS?
Yeah, very, very good question. So yes, I think all individuals that experiencing issues with fertility do have access to fertility testing via NHS pathways. So I would refer to, most of us are aware of fertility specialists that we then do tend to refer you onto. It's a good question. So outside, the CKD population, in the general population, both the male and the female would be tested for fertility issues. And sometimes, it is a combination of factors. So there's a male factor and a female factor. I think the same would still happen, even if, the chances are it's, let's say, the woman has advanced kidney disease stage 5, the chances are that it's probably her that has the issue with fertility. But I would imagine, because it's quite simple to do fertility testing in men, that the partner would still also be tested.
Now we're talking about Wales. So is there any pre-pregnancy consultants in Wales, or consultation, should I say, in Wales?
I do know of at least one nephrologist that does specialise in pregnancy kidney disease. I think she's based in Cardiff. But outside Cardiff, I don't know. But you would. So what we have in England and Wales as well, I think. I apologise, I don't know 100% if it's the case in Wales as well, but we have maternal networks where the smaller hospitals can feed into the hubs as well. So, you know, the larger tertiary care hospitals. So if there is someone that needs specific pre-pregnancy counselling, let's say they've got a cardiac issue or a kidney issue, and that's not available in that particular hospital, they can be fed into the central hub. What I can do is, if you provide, I don't know, Pete, if it's possible for that individual to just leave some contact details with you, and I can find out for them what the setup is like in Wales.
Yeah, so if anyone wants to ask a question privately, if they just put a direct message in the chat to me personally, I can forward it on. I think that's the best way.
And if they can go into say where in Wales they're based, I will come back to them.
Brilliant. Is the topic covered in the PREM report? Someone's asked.
I don't know, and I should know, and I will. I think it probably would be, I want to say, but
yeah,
sorry, at the top of my head, I don't know.
So Bladder and Bowel UK could be a help for associated issues, but I don't know if that is the case. So I think someone's saying, if you've got bladder and bowel conditions, does this affect it as well? I think that's what.
Yes, so what in terms of, yeah, I mean, obviously I focus more on the kidney side of things, but there are certain conditions which do kind of affect fertility, sexual function as well, which involve the bladder and bowel. So yeah, for example, I think someone was speaking earlier about spinal injury as well, for example. So yeah, there are certain conditions, but we've just focused on the kidney side of things today.
I'm just quickly looking through all these. There's quite a few that's saying thank you very much and a great presentation and everything else. So I'm just going through all those to try and find some questions. So very good introduction, CKD and flagging up via a route that we need referral to people. I think that was just saying how fantastic this is. Why do we get questions not answered repeatedly? I'm wondering if that's about when they go and see the consultant. I'm not sure if that's what it is.
Yeah, I think it's, that is frustrating to hear, and I think, it's incredibly unfair as well. If you do find that you're struggling with, let's say, it's just the one clinician at the unit that I work in, it's quite a big unit, and there's lots of different clinicians that cover most of the clinics. So there's always the option to then see and speak to someone else. And if you do find that you're in a situation where you're seeing the same individuals and you're not getting that advice and support, then I would suggest maybe if that's primary care you've been to, then you try the secondary care or vice versa. But yeah, I'm really sorry to hear that that issue is occurring.
Does CKD medication affect male fertility and sperm count in general?
So in terms of maintenance treatment, as in longer term treatment, there's not very many that I can think of. There's a treatment that you might be familiar with, some of you, called cyclophosphamide, and that is used in individuals with certain autoimmune conditions such as lupus and certain inflammatory conditions that affect the glomeruli. And in high doses, that can potentially impact on fertility. So, you know, in men, for example, if we're using it and time allows, we'd advise them to bank their sperm, for example. But nowadays we tend to use lower doses, and the impact on fertility is a lot less. There is some data that some immunosuppression might impact on fertility a little bit, but I don't think the signal is there that it would. It's a massive contributor. But again, you know, this is what's really important about that consultation. You would go through all the medications, all the history, if you know if there are any fertility issues.
Brilliant. I think I've answered all the questions. John Allen, I think is his name. If you wouldn't mind unmuting yourself and asking the question that I seem to have missed, please go ahead, if you don't mind. It seems like I've missed a question or it hasn't come up on my screen. So if you would like to ask the question direct, I'm quite happy for you to unmute yourself. Or if you want to ask a question via our helpline, we can forward it on as well, can't we? Yeah. So that's not a problem at all. I think I've covered everyone's questions. There is so many in the chat, very complimentary of your presentation and all the subjects you've covered. So thank you very much for that.
Thanks, Pete. I think if there is there was quite a lot of topics covered today. So I think if there is a desire to kind of like in the future have another webinar which is a little bit more focused on a particular topic, then yeah, I'd be very happy to do that.
Yeah, so this has been recorded, so it will be on our website, kidney.org.uk, tomorrow from around about 10 o'clock. So if there's anyone that you know would like to see this, we'll share it on our website, and we'll also put an email out to everyone as well with the link on it. But I think for now, thank you ever so much. Our next webinar coming up in 2 months' time is about fatigue, another subject to do with kidneys and the problems with CKD, which is also going to be a fascinating subject. So have a great evening and thank you very much. Nadia, do you want to stay on, please?